Hello, thank you all for joining us for our weight loss and fertility webinar. I am really excited to have Dr. Zarek here. She is a reproductive endocrinologist, and Dr. Niazi, who is an internist. Thank you guys so much for joining us, and I look forward to hearing what you guys have to say about weight loss and fertility. And Dr. Zarek, we'll start with you.
Absolutely. Thank you, April, for the introduction. And thank you so much, Dr. Niazi, for joining us. This
You're
is a
welcome.
really
Thank you.
exciting topic. And congrats on the viral status on TikTok. As we know, that's
Thank you.
huge. So
I
obviously
appreciate it.
that means that there is a great need for education kind of regarding your expertise. So happy to collaborate and talk through this. So yes, I'm a board certified reproductive endocrinologist, so a fertility specialist in the Midwest, in St. Louis and Missouri. That is a particular important topic, just given the lifestyle kind of in the Midwest in general. And from there, I will give it over to Dr. Niazi to kind of talk through his passion and kind of his work, and then we can get started. Thank you.
Awesome. Thank you so much. So first of all, I wanted to thank April and of course, Dr. Zarek as well. I really appreciate you both for bringing me on. As I'm sure you all know, GLPs are a real place for interest for me right now. And of course, it's been booming right now in the industry. And we've been having so many patients that have been able to benefit from it. So I wanted to first introduce myself a little bit more. I'm a board certified internal medicine physician. I've been practiced now for approximately 5 years. I actually finished residency a little over a year and a half ago. And obviously, since then, what I've been trying to get into is the telemedicine space, because we've been having so many patients, even throughout my training, that really you needed access to GLP-1s, but because of their insurance plans, weren't able to get it. And then obviously within the last few months, what's been really rewarding for me is seeing how many patients have been able to benefit from the uses of GLP-1. So I'm very excited to chat about that here today. Thank you.
Awesome.
All right, Dr. Zarek, if you want to maybe just jump in and kind of give us some insight about how weight affects fertility and kind of talk about some of the things that you've seen in that area.
Yeah, absolutely. So we talk about kind of lifestyle and kind of weight management quite a bit because it has a significant impact on fertility and reproductive health overall. The topic gets kind of mixed up with something called PCOS, or polycystic ovarian syndrome, which is kind of a subset of symptoms related to weight management. I like to say that like the menstrual cycle for women is almost like another vital sign, because it's actually kind of the precursor in terms of abnormalities with the hormones that we see even before a woman of reproductive age, starts to see pre-diabetes or pre-hypertension, or kind of all the kind of stigmata that we know with kind of metabolic syndrome and weight management. So it is actually fairly modest kind of weight management that helps a lot with fertility. So let's say someone does have a diagnosis of PCOS, which is essentially an insulin disease. And that's part of why GLP-1s are so effective for that. Really, they just need modest, like a 7% kind of decrease. I like to think of it as a decrease in body fat percentage or increase in muscle mass, not really so much a body mass index or a number on the scale. And that will help kind of improve overall reproductive outcomes. It will help kind of bring back ovulation if they're not having regular ovulation or releasing of an oocyte every month because of kind of their weight symptoms overall. So we always, always, always talk about first line treatment as kind of the lifestyle, because everything else, and the expertise of Dr. Niazi is really just meant to complement that first. It is absolutely foundational. And then we can kind of talk through what else that they can do with kind of supplements or medications to help with that overall. But ultimately, what we find with the egg, which is the biggest cell in the human body, still it is microscopic, cannot be seen with the naked eye, is that a lot of the machinery in the oocyte itself is very much so affected by glucose metabolism, by insulin spikes, as well as kind of the overall cholesterol kind of levels and metabolism as well. So a lot of those things was something that you talk about with your general practitioner and your primary care, and they are kind of directly linking to not only egg health, but also sperm health.
Awesome. Okay. Dr. Niazi, can you go into a little bit more about how the GLP-1s help kind of control and regulate all of that?
Yes, absolutely. And first of all, I want to say I think Dr. Zarek made some wonderful points earlier about how this medication can help benefit patients that suffer from polycystic ovarian syndrome and PCOS and just infertility. And one of the biggest things that I got out of just my own personal experience and research into this field was seeing that just a modest or a small amount of weight loss or a change in the patient's BMI can have a dramatic effect on the patient's fertility. But to answer your point, April, so GLP-1s is just a small acronym for a long fancy name, glucagon-like peptide ones. It's really a mouthful. There's a whole host of medications, and they've been around in the market since the 90s. But at that time, patients were not aware that they were available for weight loss. And obviously, we had Ozempic, which came out earlier in around 2016 when it got FDA approval. And after that, we found out that patients were losing weight with the medication. Then Wegovy came out, and obviously, it's the same exact thing as the Ozempic, but just a higher strength concentration. But essentially, the biggest thing that I tell patients is that we're not introducing anything new to the human body. We're just increasing the longevity of a peptide that's already naturally occurring in your body, specifically something called incretin, and that's present within your gut. And the way that works is that it slows down something called gastric emptying. Essentially, these medications just keep food in your stomach for a longer period of time, and they allow you to get full faster and stay full longer. They're first and foremost appetite suppressants. And of course, with the newer advent of the tirzepatide, which is the generic for the Zepbound and the Mounjaro, that's been incredibly popular as well because it has a secondary mechanism of action in addition to the GLP-1 activity. So it works directly on your insulin levels. And then to Dr. Zarek's point, absolutely, we're finding a lot of conditions that previously we thought were linked to something else are actually linked to insulin resistance. And of course, polycystic ovarian syndrome, we know that for many decades has been linked to insulin resistance. And this is really a rare opportunity for us as clinicians because it's the first medication really on the market that helps to target that particular problem with the insulin resistance. And one of the things I was talking about in that viral TikTok that we were mentioning earlier when we started was the fact that it's a synergistic effect. It's not just about the fact that we're regulating a patient's blood glucose, but keep in mind that when a patient loses fat, the fat is actually hormonally active. I stress this to all my patients in that it releases estrogen. So the more fat you have actually releases estrogen. So losing that fat can help to bring some balance back to your hormones as well. And then just some other things to mention. I know one of the things patients always have some little bit, they're a little bit adverse about are the side effects of the medication. So it kind of harkens back to what I said earlier on how these work. They slow down something called gastric emptying. So obviously with that, one of the things you can suffer from is nausea, which is by far the most common side effect. About nearly all of our patients that we see, we actually prescribe a separate medication to help with that. It's called ondansetron. The brand name is Zofran. It's a very common medication. But I found just from my use with patients that we can avoid a lot of that nausea by just going to small meals that are staggered and spread out throughout the day and just consuming just a lot of water throughout the day as well. And then, of course, that brings me to my next side effect, which is the fatigue. One of the things that we've done for the fatigue, other than the small meals, is adding vitamin B12 to our compounded products, which has really done wonders. And this is coming from someone who is a patient, both for the brand versions and for the compounded. One of the things I liked about our medications that we were able to add the vitamin B12, and even for me as a patient, I really felt the difference between the brand and the generic in terms of the vitamin B12 being added for the fatigue. Besides that, some other things you can have are constipation. With the medication, again, you're slowing down gastric emptying, but the water can help with that. And obviously, I would counsel any patient to have a high fiber in their diet as well. And then just the last side effect that I'll mention is the hair thinning. That's a common one that I see patients complain about. And just to that point, it's not the GLP-1 necessarily directly that's causing that hair thinning or that hair loss to occur, but it's because typically patients are not eating a varied enough diet. So I always stress to my patients, yes, we want you eating high protein meals that are low fat, low carb, but obviously don't forget to incorporate your minerals. And then we can also add biotin as well to help prevent that. But that's kind of a generalized overview, and I'd be happy to discuss more. Thank you.
Yeah, no, I mean, that's very interesting. I'd heard of some of those common side effects, but I hadn't heard about the hair thinning. That's very interesting. And it
They're
makes
very common.
sense as to why a lot of times these medications are paired with coaching so that you can continue to have that discussion about what kind of foods are you eating and to make sure that you're getting everything that you need so things like that don't happen.
Absolutely, April. Absolutely.
Very interesting. Dr. Zarek, can you kind of go into how this kind of a weight loss program would allow you or help your success in your fertility journey? Just kind of bring it together more on how this weight loss, getting healthier, can lead to your fertility goals.
Yeah, absolutely, April. That is a great question. And Dr. Niazi, thank you so much for that synopsis. That was great little kind of pearls for, even myself to kind of take away.
Appreciate it.
And so in terms of incorporating, kind of how to talk to patients and how to approach it, I think it's incredibly important in our field, just because folks are coming really vulnerable, to be very gentle about that conversation, and more that, they have to we have to meet them where they are with it and kind of provide some solutions based on that. If I may, I'm going to give a very quick kind of brief overview of fertility kind of 101. So infertility is if you've been attempting to conceive for a year below the age of 35 with regular menstrual cycles. And it's after the age of 35, it's for 6 months, after which we do fertility testing to look at hormonal profile, kind of semen analyses for sperm count, kind of the physical uterus, fallopian tubes, and ovaries to make sure that path is all clear. Those are the kind of fertility testing. And I say that because a lot of times if someone's coming to us saying, well, my cycles are irregular, they think that so maybe, a medication, a GLP-1 is going to be the thing that's going to fix it all, right? But in reality, with infertility and fertility challenges, it takes two to tango. So there's usually kind of 40% on the male side, 40% on the female side, and the remainder is kind of unknown. So we almost never see it just being only a matter of kind of related to ovulation, PCOS, and that is the only challenge with infertility, certainly kind of not in our geo, kind of in the middle of America. So I talk about this a lot. And I think the question that I actually have for Dr. Niazi as we kind of talk through this collaboratively is I think there is a ton of teaching that my colleagues and myself need related to this. But I think the first question from you as an expert in kind of lifestyle management is, how do we approach this with the patient, right? So I think a really quick kind of litmus test is, hey, REI fertility specialist, are you pro GLP-1s? Do you utilize them? Do you refer? And I think you're going to get an answer because we're talking about it all the time. And, my thought is, as we have more of these conversations, and I think that's why this collaboration is important, we're going to see more of it. Yes, it is important. It is an effective way to kind of help improve folks' health that, has been incredibly frustrating for a number of years. We're seeing fertility challenges skyrocket overall. And this is kind of one of the main reasons why. It's not the only factor, but it certainly is. So, just to put it out there, our practice at Arbor Fertility, we're very supportive of kind of our colleagues and kind of lifestyle management, and are, really want to make sure we're providing them really expert care, right? And so sometimes that is definitely a collaboration with with someone like you, Dr. Niazi, not so much because I want to be able to provide them expert care, and I know our expertise, right? So collaboration is so much better. But that said, what I'm finding, especially recently, is I will say, it may be worth it to consider not necessarily a break, but a time, from attempting conception, but a time to get really primed for your fertility treatment is how we framework it, right? To me, and they say, okay, great. I will talk to my, I'll say, and I'm happy to refer you to some of my colleagues in this space. And they say, no, it's okay. I already talked to my PCP, and, they said they'd help me with it. 3 months later it goes, and I say, so how did it go? And they say, well, actually, my PCP told me that these medications are not good when you're trying to attempt conception. So we just didn't do anything, right? And in reality, yes, technically it's true. Yes, in pregnancy, there's not enough data. But if it's going to help with their fertility outcomes, then absolutely it's kind of the first place we can start. and then move to fertility treatment. So that's my kind of long-winded way of saying, yes, it should be part of what we're offering. I don't necessarily know if the certain medications, there's enough data to say it's safe in early pregnancy because there's so much organogenesis that happens in that first trimester. But I do feel very comfortable saying during this type of fertility treatment, it's absolutely okay if it's kind of synergistic, you know. And then we'll talk about it a little bit more, but I'd love to hear from Dr. Niazi that really the only time we have to say, okay, let's hold your GLP is when we're getting ready for any sort of procedure that requires anesthesia, which in our world is an oocyte retrieval as an IVF specialist.
So I think to answer your question, Dr. Zarek, I think you mentioned some really beautiful points. And I have these discussions with my polycystic ovarian patients and patients that just have infertility in general all the time. And I think it's important to note that I think having a discussion is first and foremost the most important thing. So I always encourage every doctor to have an open dialogue with their PCP. To your point, there's some PCPs that are very against using GLP-1s during the time of conception. I think that comes from not having enough data. These medications gained FDA approval. Ozempic was 2016, so we just don't have enough long-term data. No one's really studied it around pregnancy and breastfeeding. So one of the questions we always ask at our company is whether or not someone is actively breastfeeding or planning to become pregnant. Now that term can be very I guess sort of wishy-washy, if you will, because to your point, now there's a lot of research coming out of patients using GLP-1s prior to conceiving, and then once they get within a certain range, then basically we'll stop the medication. Really, from everything that I read, it was anywhere between 1 to 3 months prior to actually trying to conceive. But the whole idea is that these GLPs are used to sort of touch up, if you will, a patient. And again, based off of everything that I saw, one of the most interesting things, and I mentioned this at the very beginning, Dr. Zarek, is that you just need a modest amount of weight loss. From all the studies that have been done from 2010 onwards, there was a randomized clinical trial, which is the gold standard. It found that just a change of a BMI between 1 to 2 points can have a dramatic increase. I think it was upwards of 60% in the randomized clinical trial. So it's pretty dramatic. But to your point, I would always have a patient try doing lifestyle modifications first. I'm not one of those doctors that likes to just automatically go towards a GLP-1. I think everyone should, of course, qualify. Typically for a GLP-1, we want a body mass index at least above 25 for PCOS patients, and generally speaking, 27 is considered for general patients that don't have any comorbidities, like, for example, prediabetes, et cetera. But there's a lot of patients who are within that range of 25 to 27 that have prediabetes. Maybe they have gestational diabetes from a prior pregnancy, for example, or they just have PCOS. So I think those patients can benefit. But to answer your question directly, about the 1 to 3 month mark is what I've seen. But to be frank, there's not a lot of data on this. It seems like a very niche industry. And again, there's a lot of cases now that are within like the last 6 months that I've seen that are studies of coming out of patients using GLP-1 prior to conception. But once they get within that 3 month range, they'll stop the medication. So I hope that answers your question. Yeah.
It does. Thank you.
Of course.
That's wonderful. Okay, so I think we have a lot of questions that tend to be around, kind of when to start thinking about this. And I know the fertility journey, I know is a really long journey. Like you mentioned, patients are trying on their own for like a year, and then they're really, getting frustrated at that point. So when do you suggest that they get more serious about things? Because of course, weight and fertility is so linked. And I think that is something that people are understanding. And so as they are attempting pregnancy, they are realizing that maybe they need to make healthier choices, but maybe they don't do quite as well on the lifestyle side. I would love to hear from both of you kind of how long would you suggest someone work on lifestyle before moving on to GLP-1s, and then eventually being able to move on to fertility treatments?
Sure. Dr. Niazi, I'm happy to start.
Sure, please go ahead, Dr. Zarek. Yes.
Sure. Yeah. So great question, April. I think that, so many folks have already been attempting conception for so long. So the last thing they want to hear from a reproductive endocrinologist is, hey, let's do another 3 to 6 months of, trying to lose weight and then come back. I mean, that's daunting and it's so stressful overall. So I would say that it's first a conversation, because as we know very well, there's many women whose BMIs are kind of considered abnormal or high, and they're fertile and they conceive, or they need a little bit of help, you know? So this is very much so, I think, not so much talking about obesity, more talking about PCOS, insulin resistance, that kind of camp of, you know, if there's someone's there overall. A lot of times what I find is that if we are starting to think that their PCOS is really affecting their fertility outcomes, which usually means that they have already gone through some fertility treatment. And then we all as collaboratively take a step back and go, we talked about this. It very well could be a major factor for you. We're learning more. Do you have the time? If this is definitely recommended, would you like to consider fertility kind of lifestyle kind of, you know, management with medications? And if they say yes, if they seem pretty committed, that's when we usually go, okay, let's go for it for about 3 months or so and see where we're at. I love, Dr. Niazi, that you mentioned that you don't usually start with GLP-1s, because a lot of times what I'll do is I'll talk through what you talk through in terms of movement, exercise, getting sunshine, you know, kind of the giving some pointers for diets without being restrictive. And I do offer, just because I feel more comfortable, because it's older, you know, like phentermine, let's say, and, you know, talk them through, you know, if you're hypertensive, maybe not a good idea. You have to get a blood pressure cuff, but at least we start there. And because, as you were saying so well, that, you know, it's such a modest weight loss that can be really helpful. You know, the phentermine sometimes meets that goal for some folks. For some folks it does, some folks it doesn't, you know. So I would love to kind of hear your thoughts about that approach. I kind of go, I don't want to just leave you and not help. So let me at least prescribe this. And then I do also encourage you to see a colleague. You know, that's usually how we go about it. What are your thoughts?
You absolutely nailed it, Dr. Zarek. Honestly, there's not much else differently I would say to your point. I think starting off with the discussion is always the way to go. And again, just not harping to the medication straight off from the beginning. I always like to have a discussion. And you're absolutely right about going outside in the sun, going for a walk. These are all really, really important things. I mean, as doctors, I think we're taught so much to just prescribe, but a lot of times we can solve a great host of our patients' problems and comorbidities by just doing common sense things like exercise and having that talk. To your point about using the phentermine before, absolutely. I'll have patients actually that come in for GLP-1s. They'll try the phentermine and it doesn't work as an option. And then we have the option for semaglutide or tirzepatide. And I think the other thing that I just want to mention is that now there's oral forms of these GLP-1s, which have been very nice for patients, because I know a lot of our patients are very adverse to having needles subcutaneously. And so we offer oral drops, for example, as an option, and even troches as well, which have been very popular for patients. But yes, I think just following a stepwise sort of pattern, having a discussion, maybe trying something oral like phentermine, and then maybe escalating to like an oral semaglutide or tirzepatide. If those options don't work, then we can try out the stronger stuff from there.
Yeah, awesome.
Nice. Okay, so another question that we have here is, how long does it usually take to see improvement in your fertility potential, whether it be ovulation, of course, is the easiest thing, or sperm health?
So for me, this is something that I saw within 3 to 6 months happen with my patients, and it was dramatic. Again, I think I said this on our initial visit as well, Dr. Zarek, and to April, but the best part of my job, I kid you not, is taking patients off of a GLP-1, because now they're finally having regular cycles again, and they're able to actually conceive. And they're telling me, oh, I had a talk with my fertility specialist who I've known for 6-7 years, and now I can finally get off the GLP-1. So it's the one time I like taking patients off of the medication, if you will. But essentially, to my earlier point, I think if patients or anyone watching this webinar takes away anything from today's conversation between myself and Dr. Zarek, is that you just need a modest amount of weight loss to actually help with this. And that's not just for the females. I know we've been talking about PCOS, but this is also for the males as well. At the beginning of the conversation, Dr. Zarek said something I really liked about sperm health. And there's papers that show that spikes in glucose levels and insulin levels are related to sperm health. So it's obviously, as to her point about the 40%, that's absolutely the case. So this issue affects both females and males. But yes.
Wonderful. Dr. Zarek, do you have anything else to add, or are you seeing the same in your patients as well about the 3 to 6 months?
Definitely agree with the same timeline of the 3 to 6 months. I would add, though, just to kind of reframe that question a little bit, that not in addition to GLP or some sort of medication help, it is also kind of, they've made lifestyle changes, because I think you need that first part if, even the GLPs are going to help. And at some point they will have to stop if they've conceived, right? And so, the question about, am I going to slide back? I think we have a better chance of success if they're already incorporating, this into their kind of daily routines, for sure. Good sleep, some moderate exercise. It doesn't have to be anything over the top. Is that kind of what you agree with, Dr. Niazi? Just being
100%.
Okay.
100%, Dr. Zarek. In fact, if I'm going to be fully transparent, one of the biggest reasons I work for Shed RX, which is the telemedicine company's dual plug here, is because of the fact that they're very comprehensive. When I was having a talk with the CEO at the time of my hiring, the biggest thing for me was having a coaching team that's available for the patients. You'll see a lot of these companies popping up everywhere that aren't really offering that. They just sort of prescribe the medication, which is okay, but there's so much more to losing weight than just prescribing a medication. To your point, the lifestyle changes are critical. Sleep is important. Diet, exercise, everything really is important, and it matters.
Yeah. Okay. Awesome.
Yeah, I agree. I think you have to have a comprehensive approach to these things. I mean, in the end, you're dealing with people, and the people are complicated, and there's a lot of outside factors. So, yeah, I think that's very interesting. So this is an interesting question that we got here. It says, I've heard that weight loss can improve testosterone levels. So have you seen this in your use of the weight loss programs?
So I have. It's a little bit more difficult for me in the telemedicine side because we don't typically do labs on patients, but I've seen this on the primary clinic side. So when I worked at the hospital or at the clinic, we actually had patients come in. In those cases, we'd prescribe the brand, but yes, we'd have labs to follow up. I saw this particularly with the men that were involved. Their testosterone levels actually went up. It kind of harpens to my earlier point that fat is a metabolically active organ in that it releases estrogen. So that's really important, is that so every time that you're removing fat, you're also in essence removing estrogen from the body. And with that, the testosterone level can go up. In the case of polycystic ovarian syndrome patients, is actually the opposite effect. The testosterone level actually goes down, and that harkens to how polycystic ovarian syndrome works. But obviously, in patients that have PCOS, the issue becomes their testosterone level is too high, and so this helps to basically reset the body's metabolism in a way. So it's really useful from that standpoint.
Interesting. Okay. And let's see, here's another question that says, they're wanting to know if a side effect of the GLP medications could be like a sexual performance side effect or decreased libido. Have you heard or seen anything like that?
I haven't directly. I've had patients tell me, April, that they feel generally fatigued, which is a general side effect of the GLP-1s. But no, if anything, it's the opposite. I've had patients tell me, and again, maybe that harkens to the increase in testosterone. Perhaps we don't really know, but yes, but yeah.
Wonderful. Well, I want to take the opportunity to allow you guys to just have some final comments while we wrap this up. I think this has been a very interesting conversation. So, Dr. Zarek, we'll go ahead and start with you. Any last things you want to impart us with?
Yeah, absolutely. I love the idea of a summary. So from a fertility specialist standpoint, I would say that GLP-1s are a great kind of new tool that we can help kind of counsel folks regarding fertility. And really, we're looking to see that within our community that it's accepted more for use, because there's been such leaps and bounds in terms of helping women ovulate again and for their overall fertility. And, I do want to emphasize that there may be other factors related to fertility, but certainly we are very much so supportive of kind of consideration of that treatment, usually 1 to 3 months before they start active fertility treatment, and definitely at least 4 weeks off of a GLP-1 before any sort of anesthetic or anesthesia needed, required procedure. And if you don't mind, Dr. Niazi, I know we didn't quite talk about the anesthesia, but I would love to kind of hear your thoughts, because our anesthesia team is very sensitive to anyone having current GLP-1 use, just because of what they find gastric contents. And so that would be great if we can also talk about that a little bit more, so patients feel comfortable telling us that they're on the medications, because the worst thing is if they don't say anything and then we don't know, and it puts them at significant risk.
100%, Dr. Zarek. I was even having this discussion with a patient the other day, because she was going into a surgery. It was not related to IVF per se, but actually based off the anesthesia guidelines, and this is current as of 2024, for the vast majority of surgeries, you actually don't have to stop the GLP-1 unless it's 24 hours before. Now, it depends on the surgery that they're doing. So if you're going to do anything upper airway, for example, or time-intensive surgery like an open heart surgery, for example, then absolutely you should not be on a GLP-1. However, this is obviously tailored to every anesthesiologist. Some anesthesiologists are just more careful, so they'll say even a longer period of time. I've heard up to 2 weeks, even without any GLP, which I think is a bit much. But usually the standard I've seen is 24 hours. But again, it does vary on the particular surgery that you're doing. Absolutely. Yeah.
Interesting. So Dr. Niazi, do you have anything else you want to say before we wrap up?
Absolutely. First of all, I wanted to thank April and Dr. Zarek again for giving me an opportunity to speak. I'm really appreciative, as is ShedRx as well, to be here and to have this conversation. I think just the fact that we're having a talk with a fertility specialist about GLP-1s is phenomenal, because I think even 6 months ago, people wouldn't even be thinking about this. But I think the biggest thing that I want to summarize to Dr. Zarek's point as well is that you just need a modest amount of weight loss to cause fertility issues typically to go away. And the other part that I'll mention is that it's not just the medications, but also incorporating that with lifestyle changes is very, very important. And I wouldn't say GLP-1 should ever be first line for any patient, but if you're someone that meets their criteria, I would highly encourage you to have a talk with your primary care doctor, for sure.
Awesome. Thank you, Dr. Niazi. I did want to thank ShedRx, as Taylor, who is kind of listening in, and Hera Fertility and April for bringing us two together, Dr. Niazi and I, and kind of the four of us. This has been really fantastic, and a lot of learning on our, side that we're going to take back to our patients. So very much so appreciated. Thank you for the opportunity.
You're very welcome. Thank you so much, guys. I appreciate it.
Thanks.
Thank you.
Take care.
Thank you, guys. Take care. Bye-bye.
Bye.